Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series webinar. This evening, we're going to be talking about expanding atopic dermatitis options for adults and pediatric patients 12 years of age and older with moderate to severe atopic dermatitis. Our moderator this evening is Dr. Leon Kircik. Dr. Kircik is president of the International Dermatology Education Foundation, clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai in New York, Indiana University Medical Center in Indianapolis, and medical director of physician skincare, DermResearch, and skin sciences. Our guest speaker this evening is Dr. Peter Leo, who is medical dermatology associate of Chicago in Chicago, Illinois, clinical assistant professor of dermatology and pediatrics at Northwestern University Feinberg School of Medicine, founding director of the Chicago Integrative Eczema Center, and founding partner of Medical Dermatology Associates of Chicago. We'd like to thank our supporter, Pfizer, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your phone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you'd like to ask a question to our faculty, please submit your questions in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and will be emailed to you 1 to 2 days after the webinar. We'd greatly appreciate it if you could fill it in for us and send it back. With 1 to 2 days after this webinar, a certificate of attendance will also be emailed to you. Again, please submit your questions in the question chat pane on the right-hand side of your screen. So without further ado, I will pass the floor virtually to Dr. Leon Kircik.
Thank you, Roxanne, and good evening, everyone. And thank you for joining us for another webinar in International Dermatology Education Foundation series. Our next slide, please. Our foundation is a nonprofit organization, and the principal mission is to raise and improve dermatology care all over the world through education, especially in underserved areas. For the last couple of years, we not only have live programs, but now we have a lot of virtual programs. Next slide, please. All over the world globally, including in the US, Canada, as well as South America, Southeast Asia, and Europe. And tonight, we are very lucky to join Dr. Peter Leo from Chicago, who's a good friend of mine, and he really doesn't need any further introduction. He is globally known as atopic dermatitis expert, as well as a pediatric dermatologist. Take it over, Peter. Thank you for joining us tonight, and welcome.
Thank you so much for having me. I'm very, very glad to be here. And I'm excited to talk about this topic tonight because I will say that there is a lot happening in the world of atopic dermatitis. When I first got interested in it more than a decade ago, there was very little happening. In fact, we were like little puppy dogs in the glass window looking out, and psoriasis was undergoing this incredible transformative changes with all these new medicines, new ideas, and atopic dermatitis was sort of left out, but that really has changed. What's really exciting now is we have some incredible new options, and there's even changes in these options, as you'll see at the upper left-hand corner of this slide, now approved down to patients 12 years of age and older for CIBINQO. So we're going to really get into this idea of expanding atopic dermatitis options for adults and pediatric patients 12 years of age and older with moderate to severe atopic dermatitis. And really the focus is going to be on one of our newer medications, once daily CIBINQO or abrocitinib. First, a couple of important disclosures we want to make. This is a sponsored program by Pfizer Incorporated. I'm, of course, being compensated by Pfizer, but everything we're going to be talking about is going to be in compliance with US FDA regulations and guidances. This particular program is not CME accredited. So tonight we're going to talk about CIBINQO, the small molecule JAK inhibitor that really goes inside the cell to work its effects. It's been evaluated in the JADE clinical trial program. We're going to talk about its efficacy, and I think it's pretty striking to talk about it. We're also going to talk about its safety evaluated in 3,500 plus patients across multiple clinical trials. And then finally, we'll talk about getting down to brass tacks. How do we start our patients on CIBINQO? How do we monitor once they're on it? How can we really guide them through this? Because this, of course, really is for refractory patients with moderate to severe atopic dermatitis. I am, depending on how you think about it, I'm lucky or I'm unlucky. That is the entirety of my career right now, pretty much. I'm almost exclusively seeing these moderate to severe refractory patients with AD. I've decided to focus on it. I love this patient population in part because they're wonderful people, but also because I feel like finally I can do something for them. There's just so much room to get people better and so many new treatments. I just love it. And the most incredible thing is when patients turn the corner and feel better and come back, and I just hear it over and over and over. It's things like, I got my life back. I can't believe it. I can finally sleep through the night. I feel like I know myself again. Like I just haven't been myself for months or years. And so it's just really exciting. But on the other hand, this is a very, very difficult and trying disease. It taxes not only the patient, but the whole family, and frankly, everybody beyond that. It taxes the people that they work with. It taxes people, of course, at school. It taxes society as a whole. So this is a difficult condition, and I think we're really grateful to have these new treatments. So CIBINQO really is indicated for refractory patients with moderate to severe disease, patients 12 years of age and older. Now, this would mean patients where we've tried some topical therapies and that's not working. And as you can read here in the indication, it's not adequately controlled with other systemic drug products, including biologics, or when those therapies might be inadvisable. And I think that's equally valid. It's both those situations. Some of the patients have tried a number of things, including biologics, to get to this point. Others, for one reason or another, they've discussed it, we've considered it, but it's not the right fit. It's important to know that it's not recommended for use in combination with other JAK inhibitors or other immunomodulators or immunosuppressants. This is a pretty powerful medicine, so we want to use it by itself. It's contraindicated in patients taking antiplatelet therapies, except for low-dose aspirin. And that's really just for the first 3 months of treatment. We'll talk more about that. And then we know that there is this boxed warning, and this we're going to go into in detail, but it will talk about the risk of infection, mortality, malignancy, major adverse cardiovascular events, and thrombosis. I think it starts with the patient and ends with the patient. So I love the fact that we can think about a patient that might come in. So this is Tyler. He's 21 years of age. He's a college student. He's really been suffering for a long time with moderate to severe AD. He has used lots of topical steroids. Maybe he's the patient who brings in a big bag full of different steroids that he's used. He's been on a biologic. So at one point they said, why don't we try an injectable agent? We have some biologics, and he's still under bad control. He's not where he needs to be. He's still using his topicals in addition to the biologic, and he's frustrated, and he's kind of in a sense of despair, I think. And we see this a lot. A lot of my patients come in and their eyes are downcast, and just the mood in the room, you walk into that room and you feel just the depression, the sadness, the sort of the hopelessness. And again, that's, I think, why it's so incredibly exciting to get people better and offer hope and try new things. And obviously I can't get everybody better. I wish I could, and I certainly can't get everybody perfect or clear or cured, which is my goal. I wish I could, but I can turn it around for so many patients. And I really think we got to watch this incredible thing happen in atopic dermatitis. Again, we've seen this in other conditions, but I like to call it the virtuous cycle of drug development. We learn a bit about a condition, then we get some medications that give us more insight. So we learn more about the condition, we get better medicines, we keep this process of refinement. And here what we now understand is that there are some key players in terms of cytokines, these cellular messengers, right? And these guys are playing a number of different roles in driving the itch, the inflammation, and the skin barrier disruption that we know explain atopic dermatitis from a pathomechanism. So IL-4, IL-13, we've heard a lot about these guys. IL-31, sometimes called the master itch cytokine, but other things like TSLP, which is one of the alarmins, thymic stromal lymphopoietin, IL-22, and so on. So these guys are all playing different roles driving these processes, and we understand that we can block them individually. We have the technology now to do that, which is amazing, and that can be very, very fruitful. But it turns out that when we think about how this pathway works, the next step from that, so we know one cell sends a messenger, the cytokine, to another cell. That other cell has a cell surface receptor. The cytokine binds to that receptor. And then the next step is that inside the cell, right, they're transmembrane proteins. Inside the cell, there is JAK and STAT, and that's the next step of the relay race, the next part of the cascade. So what's remarkable is that all those cytokines I talked about IL-4, IL-13, IL-31, TSLP, they all work through this system. Their receptors are connected to JAK, which then activates STAT, which then alters transcription in the nucleus. So you can see that here pictorially. What's remarkable is it turns out that we can block at any one of these points. And when you block at the JAK point, when you pick that enzyme to inhibit, you basically kill many birds with one stone. You block a number of those cytokines, in fact, all of them sort of at once. You can diminish that signaling, which is really exciting. So it's a different take on this problem. There are many ways, of course, to approach it, but I think this is really exciting that a lot of the ones we're talking about go through this JAK-STAT pathway, and that's really what the point is tonight. CIBINQO is an oral small molecule JAK inhibitor that actually enters into the cell. I mean, it has to not only penetrate through this, through into the body, into the bloodstream, but it actually has to go through the cells and get inside the cell. And there, it actually is going to reversibly inhibit selectively JAK1. So the JAK system has 4 major members: JAK1, JAK2, JAK3, and TYK2. This one really focuses more selectively. It's not perfect. If you look, I mean, there's some cross binding, of course, but it's selectively sort of more it has a higher affinity to JAK1, which is really exciting and blocks that signaling. And that's interesting because this is how we understand how it can do all of these things and do it so quickly. It's going to block all of those messengers to some degree by affecting that shared part of the common pathway. Now, obviously, this is still some degree of speculation, right? All mechanisms of action, we're still learning about these things. So that's why you see a caveat statement that we don't really know what all of this means, but this is our working hypothesis. This is why we understand the way that the disease mechanism is happening and how CIBINQO is actually interacting with it. So the science is exciting, and we really now have this once daily preparation that can get inside the cells and block this common pathway piece to help. But really what matters is the clinical effect, right? The proof is in the pudding, or the original statement, I think, is the proof of the pudding is in the tasting. So we have to see what happens to patients. And what we're going to show now is powerful skin clearance that you can see with more than 75% of patients showing that clearance at week 12. We're going to see clear or almost clear skin at week 12 in a group of patients. So amazing. We're going to look at itch relief, which is what the patients drives them crazy, right? That itching, it keeps people up at night. It's miserable. It's one of the most commonly pointed out terrible aspects of this disease that patients really want to address. And of course, we're also going to talk about the flexibility. What's exciting about this, it's a once daily pill that's already pretty darn flexible, but we actually have 2 different dosing strengths. So we can actually increase the dose if we need to. So here's Tyler again. He's telling us that he's in college right now. He's really concerned not only because he has visible skin disease that we can see. It's on his face. Maybe you could see it up on his neck and upper chest, probably on his hands as well. So he's worried about that, but also constant itching, right? So it's not just the signs, but it's also the symptoms. And that's important. I think psoriasis obviously is a terrible disease, and it has a huge burden on patients as well. I would never undermine that. But I kind of feel like in some ways atopic dermatitis is everything bad about psoriasis, but then the next level, because the itch tends to be even worse for these patients and even more relentless. So, I mean, there's no need to compare them, but I just think it's like if you believe that psoriasis is bad, I kind of feel like then you have to really imagine atopic dermatitis can be just as bad, if not worse, in some scenarios. And so what's exciting is that CIBINQO was studied both as a monotherapy, but also in combination with topical steroids, which honestly is the way I use it in almost all patients. I still have them using some topicals, typically topical corticosteroids. Sometimes non-steroidal agents are intermixed into this whole treatment regimen, but this is nice because this gives us a reflection of the actual clinical use that we might use, or at least shows us both ways. So we have the Mono 1 and Mono 2 studies, which are aptly named because they're monotherapy. Then we have the Jade Compare study, which had topical steroids in addition, and then the Jade Teen, a 12-week combination study, again, with topical steroids. So we're going to look at those things together very carefully. Now at baseline, we can see pretty similar across the different studies. We're going to be comparing a few different things here, but moderate to severe ratio, kind of similar, mostly moderate patients, but a really good chunk, almost 40% of the patients were severe. The mean EASI score was about the same in these trials, about 30. And that of course goes from 0 to 72. Prior systemic therapies, more than 40% of the patients in the Mono 1, Mono 2, and Compare had been on a prior systemic therapy. That would include dupilumab. We can see about 6% of the patients had been on dupilumab. In the teen study, more than a quarter had been on a systemic therapy, and about 1% had been on dupilumab. So that's good to know, and we can see the median age in terms of demographics. So what did we see? Well, powerful skin clearance results versus placebo at week 12. And I think this is remarkable because what we're seeing here is in gray at the bottom, that's our placebo group. A little bit of a placebo effect we see, but not very impressive. And then we see in the light blue, that's the starting dose we typically are going to use, the 100 milligram starting dose, 100 milligrams daily of CIBINQO, and we can see a very rapid separation. And we can see that at that endpoint of 12 weeks, 44% of the patients had achieved 75% or better improvement of their EASI score, that eczema area and severity index score. So that's 4 times as many patients on drug saw that improvement compared to placebo. And this is as monotherapy. So they were not using topical corticosteroids here. This is just on CIBINQO. Again, for a group of patients who, as we said, is by definition refractory, moderate to severe disease. Pretty amazing. And then when we look at the higher dose, which is, in the time of the study, they were studying both doses so we could see what they do. Now, as it's been approved, that would be a dose we could potentially escalate to after about 12 weeks if we felt we weren't where we wanted to be. We can see that more than half now, 61% in fact of patients were able to get that EASI 75 score. So I think pretty exciting to see that, and very, very important. When we look at the slightly more stringent one of getting clear or almost clear, the IGA 0 or 1 at week 12, we can see that the 100 milligram got more than a quarter of patients clear or almost clear, 28%, which was quite significant compared to placebo. And the 200 milligram dosing, the higher dosing, got almost 40% of patients clear or almost clear at week 12, so 38% of them. Really remarkable. What does that look like? Well, clinically, we can see someone here at baseline, an IGA score of 3, moderate on the we're looking at the abdominal area. We can see by week 2, really remarkable. I mean, it becomes somewhat difficult, at least the way it's projecting here for me. It's hard to see much disease. In fact, if you showed me this photograph at a conference and said, okay, what are we talking about? I'd say, oh, wait, what are we talking about? And then we can see at the end point at week 12, this patient received a score of 1, almost clear. So I think very impressive to see the rapid improvement here, and then that kind of dramatic improvement at week 12. Let's look at we're looking at the shin area. And again, we're seeing the moderate at baseline. And this, I think, is more prominent here. Week 2, still pretty active, quite a bit of erythema still. There's still some textural change, although it does look maybe less papular from the photo. But look at week 12, again, hitting an IGA score of 1, almost clear. Really impressive. And this is on the starting dose, 100 milligrams of it. And this is from the Jade Mono 2 trial. And then here's a 43-year-old woman on the calf, and we're seeing, again, this patient starts out even higher as an IGA score of 4, severe at baseline. By week 2, we're seeing what looks like some improvements there, and then at week 12, down to a moderate. Now, it's important to know, this is still moderate disease, and so this patient technically, by this would not have been necessarily a treatment success, because we know one of those endpoints had to be getting clear or almost clear with a 2-point improvement. And so this patient did not meet the co-primary endpoint. But I think that's pretty interesting to see too. Patients who failed to meet the endpoint still saw some improvement, and arguably quite a bit, because this is one of the fascinating aspects of the IGA score. Because it's only 5 points, right? 0, 1, 2, 3, or 4. You kind of have, there's not a lot of nuance, because you could be severe, you could be very, very severe, you could be crazy severe, the worst patient ever, and you're all 4. And so to go from crazy, crazy, crazy severe down to 3 is actually kind of a big leap, but you can't measure that. So that's, I think, interesting to see those, and that helps me understand maybe what we might expect. Even if a patient didn't reach the goal, which would be clear or almost clear, we still might see some improvement. Now here, we're looking at the EASI 75, so getting 75% better improvement on their eczema area and severity index. And here again, we can see that about 6 out of 10 patients got that with the 100 milligram dose in just 12 weeks. And you can see how fast the curves are moving up. In the 200 milligram dose, the higher dose that we could potentially scale up to if we needed, almost 70% of patients was able to achieve this, 68%. Quite impressive, I think. And then looking at the key secondary endpoint of EASI 75 at week 16. So we're seeing it ends here at 12 week, but we do have some week 16 data, and we could see almost 60% of patients hit hit it with 100 milligrams, and about 70% of patients hit it with 200 milligrams. So suggesting that we're maintaining, if not climbing, still a little bit in the next few weeks. Looking at that more stringent, clear or almost clear, right? So 75% better is awesome. It's a great, that's the number I like to keep in my head to think about different agents. And to me, that when I talk to a patient, I kind of say, this is a good sense you're going to get a lot better, you know, but obviously we would love people to all be clear or almost clear. And so looking at that, we can see here 36% of patients, so more than 1 out of 3 patients got clear or almost clear in just 12 weeks at the starting dose, and almost half at the higher dose, the escalated dose of 200 milligrams. Quite impressive, I think, there as well. Now, at week 16, again, we see what we kind of saw before, similar continuation, if not, you know, we see that similar continuation in terms of the improvement of obtaining those endpoints at week 16. What about EZ90? This arguably is very similar to getting clear or almost clear, but it's still not quite the same thing. It's getting 90% or better on that EZ score. And again, we can see at week 12, 37% of patients on the 100 and 46% of the patients on the 200 milligram dose were able to achieve that 90% or better improvement on the EZ score. Really impressive. And similarly, at week 16, it was roughly the same. What would this look like? You can see this here. Now, this is a patient who was also on topical steroids. We see severe, an IGA score of 4 at baseline. At week 2, to me, this is quite dramatic. We're seeing this improvement, and at week 12, an IGA score of 0, clear. So really impressive to see that 4 points all the way down from a severe down to clear. Really impressive. Now, this patient notably, again, was on the topical steroids and was on the 200 milligram dose. Patient here, we're looking at the belly area, severe at baseline. By week 2, I would argue a very dramatic improvement, and at week 12, clear again. So 0 on the IGA score, clear skin. Again, 200 milligrams concomitant topical steroids. That we could do for anybody, but we would start at the 100. We could increase that dose after 12 weeks if we feel that the improvement is not adequate. Okay, what about longer term, like 12 weeks, 16 weeks? This is good, but this is potentially a lifelong disease. So we can see here at the end of JADE Compare, JADE Mono 1 and Mono 2, we could see that the patients were re-randomized, and they were then put in this extend trial to go on with topical steroids if they needed it, and we could track them out all the way out to week 92. Which is really neat. So we're going to look at this, and we're going to look at some of the different endpoints from the extension here. So when we look at this, we can see at week 48, long-term skin clearance responses, really impressive. And we can see, look at the shape of these curves. We see the rapid improvement up to there at week 12. That was one of our earlier endpoints. And then we can just see how sustained it is all the way through week 48. This relative flat line is exactly what we want. You know, we don't want anything interesting for this. We want people to get that success and keep it. And I really think that's what we're seeing here. And in fact, we can see, and they're showing kind of both different studies here in the dark blue and the light blue, and then the dotted line versus the solid line is the NRI, so the imputed versus the observed, and they're just slightly different ways to count it. I love that we can see both, so we can actually see, we think the truth probably happens somewhere in the middle, so in a way you can see, but the truth is they're somewhat close together, so that's helpful. And we can see about 66% of patients were still at that EZ75 point at 48 weeks in the 100 milligram, and almost 82% as observed in the 200 milligram, which I think is really exciting. And looking at 0 or 1 IGA score, again at week 48, and it's a very similar story, I think. Look at that beautiful long-term skin clearance response. We see that sustained, and again, we're seeing both as observed and the NRI to give us a little sense of potentially the range, depending on how you count that. And sometimes you'll see it in different studies, so I love when they show both, because then you can say, okay, we get a sense sort of where it might be. Now, they did a post hoc analysis from JADE Extend, and what we're looking at here is kind of interesting. Patients that were defined as dupilumab non-responders. Okay, so these are patients who received dupilumab plus topical steroids, but didn't achieve the endpoints with that regimen. So these guys were then able to, we're going to look at them and see kind of how they did, which I think is really exciting. They were randomized to get either 100 or 200 milligrams of CIBINQO, again, plus or minus topical steroids. And what's really nice is we can get a sense of how it might work in this kind of a setting, which again, for me is actually really a common scenario, but there are some limitations. This is a post hoc analysis. We have to be a little bit careful. So there's a lot of different things that we can lose. This is not a randomized double-blind control trial for this particular question, right? We're applying this on a group that was already part of this. So it's just good to know these patients at this point did not have a placebo control. So we have to be a little bit careful of efficacy improvements. They can be partially due to the awareness of receiving an active treatment. So there are some important caveats, and we want to always make sure. But this is what was seen. So this was people who prior non-responders, they weren't able to meet that. And we can see that the percentage of patients who achieved the improvement in lesion extent and severity to get the IGA 0 or 1, so clear or almost clear, more than a third of patients on the 100 milligram dose, and almost half of the patients, again, dupilumab non-responders, were able to achieve that on the 200 milligrams. If we take the slightly more open EZ75, maybe a little easier to attain that. Again, I think this is very, very impressive. 68% of the patients on the 100 milligram dose, almost 70% of non-responders were now responders on CIBINQO, which is really neat, and almost in 80% when we use the higher dose. So I think this is very exciting, and I can just tell you very honestly, my clinical experience is very much in a group of patients just like this, and this is very reflective of what I'm seeing. So that's really nice. That's also reassuring because I have a number of patients who are exactly in this group, but remember those caveats. That was a post hoc analysis. Okay, powerful skin clearance results versus placebo at week 12, even in our pediatric patients down to age 12. So this is 12 to under 18, and we can see arguably very similar to what we see with EZ75. 64% of pediatric patients got that endpoint of EZ75 at week 12, 71% achieved that on the higher dose of 200. And when we look at the co-primary endpoint of IGA 0 or 1, so clear or almost clear, almost 40% of patients on the 100 milligram dose. So just about 4 out of 10 patients got clear or almost clear skin with CIBINQO 100 milligrams daily. That's news worth spreading, right? I think that's pretty neat. And rapid and significant itch relief, again, as even monotherapy. So we talk about the signs, but also the symptoms. Really important that itch is a huge problem. And here we're looking at, this is the PPNRS4. So getting 4 points or better improvement on that itch scale. So from 0, no itch, to 10, the worst itch imaginable, you have to get 4 points or more to be considered a success there. And arguably, you know, that's an important, I think that's clinically meaningful for sure, but it's kind of a high bar, 4 points. We can see 11% of the patients got that 4 point or more improvement in itch on the 100 milligram dose. And this is at week 2. So this is only at week 2, which is, I think, very exciting. And we can see 24% of patients on the higher dose. In other words, 5 times as many patients taking the 100 milligram got itch relief compared to placebo as early as week 2. So the other interesting facet of this drug that I think is really worth thinking about is the speed. And it's hard to capture it sometimes because depending on where they take these different endpoints, you know, we're kind of focused on the endpoint. But this is exciting because we're looking at week 2, which is, you know, just a few years ago, I would have thought is, you know, pretty hard to attain that. And again, we can see in the JADE Compare studies, at week 2, a higher proportion of subjects got itch relief with both 100 and 200 milligrams of CIBINQO compared to placebo. And we can also see here, this is kind of interesting, there's an active comparator arm with dupilumab. And so it turns out that at week 2, similar proportion of subjects achieved itch relief for CIBINQO 100 and dupilumab. They were pretty neck and neck, but at week 2, a higher proportion of subjects achieved itch relief with the 200 milligram dose compared to dupilumab, and you can see that about 30% versus 13. So again, even though we're starting everybody on 100, that's the recommended dose, we have the ability to go up, and I love that flexibility. So if we're not where we need to be, then we can say, listen, we think we want to go higher in this particular case, which I think is really important. And of course, the proportion of pediatric patients who achieved this PPNRS for the 4 points or greater improvement was higher in the CIBINQO 100 and 200 compared to the placebo, which is wonderful. And these are really putting all this together and helping us when we have our patient like Tyler, who is now open to the new treatment. So maybe we've kind of dazzled him by talking about some of these really impressive efficacy, not only the depth of improvement, but also the rapidity, the rate of improvement is so exciting. But now he has a good question. I'm open to this, but I want to better understand the potential side effects. So that brings us to our kind of other big piece that we have to make sure we cover in detail for our patients, which is the safety considerations. Now, this class of medicines has a boxed warning. And I think it's really important that we go over it with our patients, because one thing I think that can be really off-putting to patients is if we don't talk about it much or dismiss it, and then they hear about it somewhere else, maybe from the pharmacist, maybe from the prescribing information. And I think that can really shake people up. They say, wait, you didn't tell me any of this, or you made it seem like these weren't an issue. So I think it's really important to go over them carefully and explain to the patients and put enough emphasis on it and put it in context so they understand. And the first things, I say, this is an important summary. This is an important warning that I'm going to summarize for you right now. I'm going to give you some reading material. I want you to read it and you can ask me questions. You don't have to understand everything right now because there's a bit to talk about. And a lot of times if a patient seems even a little bit hesitant, I'll say, sleep on it. We'll talk about it in the next day or two. Don't feel pressure. You don't have to decide right now. And I think by taking the pressure off, my own experience is many patients who might have trepidations, they feel better about it. It's like, okay, it's not a hard sell. I'm not trying to say you have to take this now. You have to decide right now. Nope, you can think about it. And I feel almost all the patients that I've offered CIBINQO to have taken me up on it. And the couple that maybe didn't right away, usually a day or two later, said, okay, I think you're right. Let's try it. And I think that's important. So what do we go through? Serious infection risk. Well, this is a medicine that is going to decrease inflammation. It's going to push our immune system down, and the immune system is also important for fighting infection. So serious bacterial, fungal, viral, and opportunistic infections can occur, and they can even lead to hospitalization or death. This would include things like tuberculosis. Now, the most frequent serious infections reported with CIBINQO were herpes simplex, herpes zoster, or shingles, and pneumonia. Of course, if something like this were to happen, we'd want to stop the drug right away and let us know. And we're going to do everything we can to make sure we avoid things. So we're going to test for our TB before starting. We're going to do a hepatitis screen before starting. We're going to avoid the use of it in patients that have an active infection. So all of those things I tell my patients straight up, and I say, although we think the risk is very low for something like this, it's real, so we have to be vigilant on this. And of course, this is a class-wide warning. I tell them there are a number of medications in this class that have a similar warning. Mortality rate, higher rate of all-cause mortality, including sudden cardiovascular death, has been seen with another JAK inhibitor. Now, I explained a little bit about that today. I say, this is really tough for us because it's a different medication. It's not CIBINQO that was studied in that study. It was in a different disease. So it was actually in rheumatoid arthritis patients, and it was patients that were kind of special. They were over 50 and had one major cardiovascular risk factor. That makes it a little tough because we don't actually know. When patients say, what does that mean for me? The honest truth is we don't know, right? We just don't know. But out of an abundance of caution, we want to tell you what happened there. And we, because it's the same category, we just want you to be aware that this is potential. And we know that this is not used in rheumatoid arthritis patients, and that drug is not approved for atopic dermatitis, which was, of course, tofacitinib. So these are different things, but we do explain that in that trial, they saw a higher rate of all-cause mortality. They saw higher rate of malignancies as well. And we know, of course, in that study, they had a higher rate of lymphomas and lung cancers. We know that patients who are current or past smokers seem to have additional increased risk. Malignancies have occurred on patients on CIBINQO, but again, we don't exactly know what does that mean. Can we give a number? We really can't to a given patient. We don't have that ability. Major adverse cardiovascular events, or MACE, also were seen to happen more often in patients on that other JAK inhibitor, tofacitinib, in the rheumatoid arthritis study. So again, we think that current or past smokers are at increased risk. We want to discontinue the drug in patients that have experienced a myocardial infarction or a stroke. Thrombosis has occurred with CIBINQO, and there seems to be a higher rate of things like pulmonary embolism, venous and arterial thrombosis with that other JAK inhibitor, and potentially has a class-wide effect. So we want to be careful and observant. We want to avoid it in patients who might have a higher risk. And of course, at the first sign of symptoms of thrombosis, we'd want to discontinue the drug and treat appropriately. So I go through those just like that, basically for the patients. And sometimes they are a little nervous about it, but I think we can ask questions and go through it to make sure they feel comfortable. And what I usually also say is that this is a powerful medication that, as you saw, can do a lot of things. So, we get nothing for nothing. It's a powerful medicine, so we have to treat it with great respect. Now, here's some of the interesting pieces. Tofacitinib, it was studied in that group, and this is telling us a little bit more about it. So it really was a different population of 4,300 patients with moderate to severe rheumatoid arthritis, and this was the people that actually had that despite using methotrexate. And they all had at least one cardiovascular risk factor. We're all 50 years of age and older. So it's a little bit strange. And this was designed to look at this population. But here's the other thing. It wasn't against just a control group. The control group was on a TNF inhibitor. And we know that TNF inhibitors may affect some of these. So again, we're looking at differences. I just don't know. And that's the problem. Patients will sometimes grill me on it. And I say, I don't know. The most we can do is sort of say, this is what we saw, and we're not sure what it might mean for you. And then I really try to focus on what we really did see in our patients with atopic dermatitis on this particular JAK inhibitor, abrocitinib, CIBINQO, and talk about what these risks are, because this at least is a little bit more tangible for me. But we can't dismiss those. We can't throw those away. We talk about them, and then we say, but what did we see? Well, the good news is we saw a relatively reassuring safety profile. And these are looking at the adverse events of special interest, serious infection. You can see relatively similar to placebo. Herpes zoster, a little bit of a signal there. I think that's something. Malignancy, fortunately, was all 0 here, which is wonderful for the excluding non-melanoma skin cancer. The non-melanoma skin cancer, really just the one right there we can see. Major adverse cardiovascular event, again, similar across the groups. Pulmonary embolism, again, just a very tiny signal. It's hard to know what to make of that. And DVT were 0s. So this is really reassuring to me in a way, but what can you say about this? Well, these are relatively few patients. That other study had 4,000 people. This one is only, several hundred, 608 we can see. And we're looking at these per patient years, how we're actually viewing these. So we know that in general, I would say the safety profile has been well studied in larger groups, so over 3,500 patients, 12 and up, across multiple clinical trials. And some of the patients have actually had 2 years of exposure. And again, what we see, I think, to me, my interpretation of this is fairly reassuring. The serious infections we can see per incident rate per 100 patient years, relatively low numbers. Herpes zoster, we're seeing, again, relatively low number, but I do think a signal. Malignancy, a very, to me, reassuringly low, not including non-melanoma skin cancer. MACE, the major adverse cardiovascular events, to me, relatively reassuring. Pulmonary embolism and DVT. So I think when we actually look at these numbers, to me, they seem reassuringly low. They're not 0. We can't say these things won't happen, but my sense is that these are generally reassuring. There are many limitations and potential biases of looking at an extension trial like this. They're conducted under differing conditions, and we know that some of the patients that make it to the extension part, they've already been selected out for other reasons. The other people were already gone. So there's all sorts of important issues whenever we look at the extension type data that means we have to be a little bit careful. But I think it really does give us a bit of a sense of its overall safety and what we can think about and what we can counsel our patients on. There are some contraindications. The big one really is patients taking antiplatelet therapies, with the exception of low-dose aspirin, for those first 3 months. So I've had this come up a couple times, and I've talked to the cardiologist, and we can figure out what to do for the first few months. Sometimes it means going on aspirin for a few months and then switching back. And I think it's just good to talk to the patient, talk to their cardiologist or whoever's managing their antiplatelet therapies. There are some lab abnormalities that have been reported, hematologic abnormalities, lipid elevations as well. And so we're going to talk about those in a little bit more detail. Immunizations, ideally, we want to make sure patients are up to date with their age-appropriate immunizations before starting. And the most common adverse reactions were nasopharyngitis, nausea, headache, herpes simplex, increased blood CPK, dizziness, urinary tract infection, fatigue, acne, vomiting, oropharyngeal pain, influenza, and gastroenteritis. So we'll talk a little bit more about those things as well. So when we look at the most common adverse reactions, these are greater than or equal to 1% in patients taking CIBINQO up to 16 weeks. We can see the big one, nasopharyngitis. We see, again, the nausea, headache, herpes simplex, fairly reassuringly low numbers when you look at this. Now, these are the percentage of patients. The other ones were incident rate per 100 patient years. We see one of the highest ones is blood CPK increase, but we don't necessarily have to measure that because it wasn't really associated with any clinical issue. So I don't measure that, but it's good to know. I think if somebody incidentally saw that, a few percentage of patients might have that. And then the acne, we know, can be a class effect as well. JAK inhibitors seem to have caused acne in some patients, so about under 2% in the 100 milligram group, but almost 5% in the 200 milligram group. And we can see some other things, impetigo, the oropharyngeal pain, and so on. So I think there are a cluster of things we want to be keeping an eye out for, but relatively low levels. We're talking in the single-digit percentage, and some of these are less than 1%. To me, one of the big questions I think is fascinating is what was the discontinuation rate? Well, for placebo, we can see 9% in the Jade Mono 1 and 2, in Jade Mono 1, in Jade Mono 2, 12% discontinuation rate for placebo, almost 13%, and then 3.8% in the compare. And we can see those numbers are actually, in general, numerically higher than what we're seeing for the patients on drug, which is really neat. I think that's reassuring to see that the people on the drug were in general either as much or less likely to actually discontinue. So that's a reassuring thing for me. So how do we start our patients on abrocitinib, on CIBINQO? What do we do? Well, as we've said a few times in this presentation, the 100 milligram once daily is where we're generally going to start. But if an adequate response is not achieved with that dose after about 12 weeks, we can consider going up to the 200 milligrams. And then that's a nice thing we could potentially do for those patients. It can be used with or without topical steroids. We want to take it about the same time each day, but with or without food, doesn't matter. Because of the form of the tablet, we don't want to ever crush it or split it or chew it. We want to just swallow it whole. And they do actually make a third dosing regimen. There's a 50 milligram dose that could be used in patients with moderate renal impairment or patients who are on strong CYP2C19 inhibitors, or if they're poor metabolizers. So that one you can get, but it hasn't really been studied in the trial. So, I think it's there if we needed it. Hepatic impairment, you can use it unless it's severe, and there it's not recommended for use. For renal impairment, for moderate, then you could consider doing the 50 milligram, that special one, and then you could actually consider bumping up to the 100 milligram daily if they weren't responding to 50, so we sort of scale everything down. But for severe renal impairment, it's not recommended for use. There are a couple of drug interactions we want to be aware of. Strong CYP2C19 inhibitors, so we want to keep an eye on that. We talked about the lowering of the dosing. We want to be a little bit careful for the strong inhibitors of both CYP2C19 and CYP2C9, like fluconazole. That one comes up in dermatology. Same thing with rifampin. So those are drugs we might use in derm, especially. And then digoxin, we want to be a little bit careful with, again, because we know that there can be an effect and you might have to titrate because a small concentration change could really cause big trouble for these patients. And that's the same story for antiplatelet therapy drugs. I can tell you my own personal experience. I had a patient who was on an antiplatelet drug, and sometimes they switch, but one of the more recent cases, the cardiologist said, we're not going to change it. I'm just going to watch them very closely and do more monitoring. So obviously I leave it to the cardiologist, but they were fully aware. We were all together on it. So that was neat. And really just for those 3 months, I think is the key piece where they're watching that. We know we want to go over all those risks with our patients, and then we want to screen for those things. We want to screen for serious infection at baseline, and ideally throughout treatment, probably at least annually, we'd be doing a TB test and a hepatitis screen. But of course, we're looking in general at serious infections, any kind of signs or symptoms. CBC at baseline, of course, ideally 4 weeks after dosing would be good too. And then throughout treatment, I think you have some flexibility. There's not really telling us, my own personal approach has been to do it every few months, depending on the patient. Lipids, they don't recommend baseline here, but I do a baseline. I think it's a reasonable thing to do just to get a sense of where they're at before starting the drug. I think that's generally good practice, but 4 weeks after dosing, initiation or an increase, of course, it's good to check it again. And then again, we could sort of manage the patients according to clinical guidelines. It's kind of vague. I'm kind of thinking about this maybe every few months when we're doing blood, maybe 3 to 4 months, but your patient could vary. So you're kind of tailoring it. I think that's why they leave it a bit open. Immunizations, we want to have them up before, ideally even herpes zoster if you can, because most patients will actually qualify because this is technically kind of in the immunosuppressant class. So they could actually qualify for the herpes zoster vaccine. MACE and thrombosis, we're just going to consider the risks and benefits for patients and keep an eye on them. And same thing with malignancy. I think we want to let them know, be good about the sun protection, be checking their skin, because in theory, they could have a little bit of a higher risk. In 5 clinical trials, including the long-term extension trial, you can see thrombocytopenia was pretty rare, 0 in the 100 milligram, and we can see 0.9 per 100 patient years. So pretty small numbers, but it could happen. So that's why we're checking that. Lymphopenia, lipid elevations, and the CPK being the most common thing to see. These are relatively low incidence numbers here. I think it's just, we just have to keep an eye on them. So who might your patient be? Who's a good candidate for CIBINQO? Well, I actually think that this patient really is. Tyler is somebody who's done everything right. He's trying all these different things and he's ready for something different. He's still pretty miserable. He's using his moisturizers. He's using his topical steroids. He is on a biologic. And, you know, I think a lot of people would have done okay at this point. You know, the majority of people maybe are going to be all right with all this, but he's not. So this is individualizing that care. He's still really unhappy, scratching a lot, and he's still really moderate level. He's an IGA score of 3 with about 25% body surface area. So this, to me, would be a perfect patient to talk about CIBINQO, to explain the pluses and minuses, to really give him a sense of what to expect. And of course, we'd be doing our labs and doing our careful check-ins, but I really think we could see a dramatic improvement. I have patients just like Tyler who've done beautifully.
So Peter, thank you so much for that really, really very illuminating, very detailed lecture. I think always I listen to you and I listen to you, I learn something. So we have a couple of questions as time allows. One question is, those people who had the zoster in the study, do you know if they had Shingrix or were they vaccinated or not?
That is a great question. I think I'd love to ask that for medical affairs. Maybe they can help us figure that out. I don't know that offhand.
Perfect. Okay, I think that's really a good question, but it would be nice to have the answer. Now, I have another question related to that. Do you give or do you vaccinate against zoster before you start them?
I definitely encourage people to do it because they are technically immunosuppressed and they can get the vaccine. And I really think it's a good idea. I think some patients, especially if they're anxious about it, I think it's a great thing you can do. One problem that is real is that if they're really eager to start, you know, sometimes it's hard to tell them, all right, well, we got to wait till you get the vaccine and, you know, and so on. So some patients I've started on it. And then I said, listen, if we want to, we can at some point potentially pause and do that later. But I definitely think if you have the luxury, it's a great thing to do.
So do you pause the treatment for the vaccine, even though it's not a live vaccine?
So thank you for bringing that up. I mean, I think that's the hardest part. So, you know, we have two concerns with vaccines. If they're live attenuated, that's a no-go because you're worried that even though our body should fight it off when you're on an immunosuppressive, it could potentially cause disease. But if it's non-live, right, like the shingles, the newer shingles vaccine, like the COVID vaccine, like the influenza shot, you should be okay. Safety-wise, you should be okay. The question there is, will you mount a response? So I get a little nervous in this venue, you know, maybe privately we can talk a little bit more about what we do, but in this venue, I think, you know, the best guidance, sort of the most above board, is to say, do it before. And I think you could do it while on, but then you worry that maybe they won't mount the response. I think the second best option would be to pause for some period of time. We could talk about how long, get the vaccine, restart after a period of time we know they've mounted. That'd probably be the second safest thing to do, but absolutely right. Practically speaking, sometimes you say, listen, you got to get your COVID booster, you know, for work or for school, if they're mandating, that would be okay. Go ahead and do it. It might not be as good, but it's certainly better than nothing, right?
Correct. You know, I really don't know. Maybe you do. If not, maybe we can find out from their medical team. Some drugs, especially the biologics, right? We do vaccine studies just to see, to answer that question, if they will get that response to the antibodies. I don't know if CIBINQO had that study or not. I'm not aware, but it would be nice to find out from the medical liaison people.
It would be great. It'd be great to see what they studied it with too, right? To see if the titer so on. I love that.
So then there's another question, which is, I think it's very appropriate in the sense that you mentioned about tofacitinib, you mentioned about all the adverse event that is a class effect in the box warning, comes from that study that they studied those patients who were 50 years of age or older with at least one cardiovascular risk effect. That was the rheumatoid arthritis patients, right? So can you tell us a little bit about that study? Why would they pick the people more than 50 years of age specifically in that study? What were they trying to see?
My understanding of that study really was that there was a safety study. They were really trying to get a sense of longer term safety across a large population of patients that, probably do have a higher risk factor for a lot of these things. Rheumatoid arthritis is a really bad systemic inflammatory condition, having a cardiovascular risk factor. I mean, all these things. And I think it was reasonable because they wanted to get some numbers on that group. And then the hard part is, how do you apply it to our patients? I think, right, we'd get reprimanded if we took a different drug in the same class and tried to make a claim. Oh, it helped, this drug helped rheumatoid arthritis 90%, so it might help. They say, wait a minute, that's a different drug, a different disease.
You can't do that, right?
But with safety, it's a little different. I think trying to be extra cautious, I get it. They don't want to, nobody wants surprises with safety. So heaven forbid. And I think the biggest thing is we're going to keep learning about it. All the data we keep getting from our population with this particular drug, I think is reassuring. It's not zero though. I mean, it's still a powerful drug. So I think you have to be balanced. And I've heard clinicians be like, oh, I'm not worried. And I'm like, that might be a little too flippant. But I think we have to be careful. But I really think for the appropriate patient, my patients are lining up. They're saying, I'm ready to take it. I always tell the funny story. I had a patient, I brought in a sample. And I said, take this home, we'll talk about it. You have a sample to get started. And she opened the bottle and I thought she was just going to look at it. She took the pill, had her water bottle, took the first pill, she said, I'm ready. I said, all right, I guess you're ready to go. She said, I need to get better. She was really miserable. So for the appropriate patient, it's a risk benefit like anything else in life, but I think the risks are far outweighed by the potential benefits for these patients.
Absolutely. Now that you brought it up, where do you fit this in your practice? You said the appropriate patient. What would it be in your practice? What would that be?
I'm looking for, the patients who are still really suffering. They've optimized their topical care. And then I really like to present the systemic options kind of together. And I include phototherapy. The next steps would be, do we want to do phototherapy? We have these biologic agents, we have the oral agent, and I like to talk about the pluses and minuses. So some patients say, I can't do phototherapy, it's too cumbersome, I'm traveling. Other patients say, I have needle phobia, I don't want to do it, or I tried a biologic and I failed that. So those are the patients, or a patient who says, I just need to be better as fast as possible. What would be the fastest thing? Because I've had patients who are telling me they want to hurt themselves. And so I'm on the phone with the psychiatrist and talking about what we're going to do for their eczema. And I think those are the patients where I'd say, listen, I think this has the best chance of getting you better very, very quickly. As we saw, even in patients who had potentially failed dupilumab, there's still an excellent chance of getting people better.
Do you still think most people prefer a pill a day versus a shot?
I think most people do. I think a pill is really nice. And I also will say this, even though, we have the risks of infection and so on, one nice thing about pill a day is you can stop it and it's out of your system pretty fast. And I tell my patients that too, you are in control. With the shot, especially some of the psoriasis ones that have a 3-month, it's like, well, it's in now, now you kind of have to wait it out, but these, you have good control. So I do think that's reassuring.
Correct. The other thing that you brought up reassuring, now, when this drug came to the market originally, we did not have the label all the way down to 12 years of age. It was 18 and above. And now it just recently got approved, which is great news for our pediatric patients, all the way down to 12 years of age. How do the patients feel about that? Does that give a little bit more reassurance about the safety that it's approved all the way down to 12 years of age?
Absolutely. Not only because my practice is about half pediatrics, so I have a lot of adolescent patients as well. So not only does it really open the door for those patients, but you're absolutely right. It puts a halo for better or for worse. And I think, we have to take it in context, but I really do think patients like to hear that yes, even in this younger age group, it still is approved. And I think that is a vote of confidence for a medication. I think it really is.
Yeah. Let's talk a little bit about the dosing, right? So the suggestion or the recommendation is that you start with the 100 once a day, and then if it doesn't work, after 12 weeks, you go up to 200. Is it possible, if you think in your judgment the patient is really severe, may need maybe higher doses, is it possible to start? Do you do that in your practice with the 200?
I haven't, and I'll tell you a confession. I actually only have one patient on the higher dose right now. Almost all my patients have responded beautifully to the 100. So really, I think it's such a powerful medicine that most of the patients that I've seen really do well with it. But I like that option. My fear is if you tried to start with 200 is a couple-fold. One, insurance might push back and say, wait a minute, not the normal. Number two, heaven forbid if something happened, I feel like people would say, boy, you didn't even try the 100. Like, this is such a powerful.
Yeah, and that all makes sense. Now, the other thing, you said something, I think it's very important between the lines. I was listening to you when you were reading the recommendations about the blood test, and you said you do the triglycerides and some of those, even though it's recommended later on, at baseline, which really does make sense, right? Because if you don't know the baseline, almost why to check the 4 weeks later or vice versa.
Right, and we all know, the confusing thing when you actually have to take care of patients is if it's even a little bit elevated, maybe not in a range where you'd actually treat, you're not worried, but then the patient says, is this from the drug? So you got to know a little bit about it, otherwise, right, you're going to get stuck in these loops. So
what other tests do you do for baseline? A lot of people want to know, like, what do we do? What you as an expert, nothing to do with the guidance or the recommendation, but what do you do in your clinical practice as a baseline?
Yeah, so my own personal practice, I do a tuberculosis test, hepatitis, I do a CBC, a CMP, and I do lipids. And then often I'll offer an HIV test. If a patient has any question, I'll say, let's do it because they weren't in the study and we want to make sure. And a lot of patients say, sure, let's just do it so we don't have to worry about it.
Yeah, you know what? It's funny. I do the same. I just do the same. And I think it's, as you said, it's good medical practice just to check those things, because I don't think you want to give an immunosuppressive drug to somebody who may be immunosuppressed without knowing it, right?
Exactly.
So what other recommendations do you have? We are almost done. And what other recommendations do you have for those of us who are trying to sort of start, the oral JAKs in the atopic dermatitis population, and appropriate patients? What else should we look into? What else should we do or not do for that matter?
The biggest thing I can say is make a 2-week check-in. It doesn't have to be a visit. I know practices are so busy, it's hard to get someone in,
Right.
but I usually say, just leave me a message in 2 weeks or send me a message through the portal, because so many of them are already doing better. It's so great. It's such a neat moment where I tell them to set a reminder in their phone or on their calendar, and they say, oh my goodness, I am so much better. I feel improvement already. And I think there's something about it. I'm willing to wait, for some medicines to kick in, but as a class, the JAK inhibitors work at a crazy fast rate, and I think that's one of their strengths. And I think the buy-in from the patient, they say, wow, 2 weeks, and they really see this beginning change. Obviously, you're going to keep getting better over the week 12 and maybe even beyond, but I think it's such a powerful moment, and what a great connection. And they're in and they're doing well. It's just a great check-in point.
Well, we got a couple of more questions that I think we should answer briefly. What would you treat a patient with a history of, would you treat a patient with a history of prostate cancer treated 10 years ago with radioactive implants and who's discharged now from the oncologist? That's really a very relevant question. It happens every day.
Yes, it is a tough one. I think that, I would really, so the answer is yes, I probably would, honestly. And I would talk to the patient in depth about what we're doing this for, what we expect, what we're going to be looking out for. Ideally, even if they've been discharged from the oncologist, I would love to get the oncologist involved in that discussion too, because if the oncologist was really nervous and said, no, it was a hyper aggressive thing, and I'm not, then I would probably say, well, we're going to go with them. But the ones I've talked to so far in a similar situation have said, yes, I think it's fine. And I will tell a patient like this, look, we're probably not going to be on this forever. I'm not going to have you on this for 20 years, but maybe we'll do this for 6 months, a year, a couple of years, and we can take a break and we'll be watching you. So I think in the appropriate context, it could work, but you have to have real good buy-in. You need all parties together, and I think you need to have the shared decision making.
You know what? Ironically, I do the same thing. I always share the health and wealth with the oncologist or with the pulmonologist if I'm dealing TB with the appropriate person. In this way, as you said, I like that shared decision making, not only with the patient, but also with the other specialists. I think that really makes it better clinical practice. I thank you so much. Roxanne showed up. Basically, she's telling us time to go. I thank you very much for a wonderful, wonderful lecture. And I thank you everyone for sharing your evening tonight with us. And we'll look forward into the next IDEF program. Thanks everyone. Good night.
Bye, everybody. Good night.